Hi, in this session I'm going to be talking about venous thromboembolism, also called thromboembolic disease, a really common manifestation of haemostasis not gone quite right and gone a little bit too much towards the thrombotic end of the spectrum. So we're going to revise a little bit of haemostasis and how that works so that we can understand how it can go wrong. We're going to talk about how we classify venous thromboembolism between pulmonary embolism, deep vein thrombosis and some other rarer forms, how we treat it and how long we treat for, the duration of therapy, the complications that can arise from VTE, and then some special considerations and when to refer to haematology, because a lot of VTE does not need haematology input, but sometimes it really does, and that might surprise you when. So let's revise a little bit of haemostasis first. So I like to really break down things into very simple steps, and within haemostasis, which is really the balance of clotting and bleeding at its core, to form a clot, we first need to have a platelet plug activation. We call that primary hemostasis, the platelet plug formation, and the trigger that causes primary hemostasis to occur. And then that platelet plug is cemented by the fibrin that is released from fibrinogen, and that is called secondary hemostasis. So when you think about the clotting cascade, when you talk about clotting factors, that's all part of secondary hemostasis and maintaining the right equilibrium of clotting and bleeding. And then to resolve the clot, when the clot has served its purpose, ideally, we have fibrinolysis, so breaking down of that fibrin mesh that then allows the clot to dissolve and either normal flow to resume or tissue that may have grown over the area of clotting if it's an injury. So really simply, you can think of that primary hemostasis is the platelet plug, secondary hemostasis is the fibrin mesh or cement, and fibrinolysis is clot dissolution, so resolving that clot when it's served its purpose. And you can see here on this picture, it kind of breaks it down into where there's an endothelial damage of a blood vessel and how that primary hemostasis forms the platelet plug that is cemented in, and then later there will be fibrinolysis to release that again. So within thromboembolic disease, we can classify the most common manifestation being deep vein thrombosis, and that's separate from superficial vein thrombosis, which is often associated with thrombophlebitis, does not typically require any anticoagulation at all. Deep vein thrombosis can be classified into below knee, so below the popliteal vein, those that are proximal DVT, so that's popliteal vein and above, all the way up to the iliac vessels. And then there are unusual manifestations that you might not see very often. So upper limb is a special consideration because of the very particular kinds of etiology that result in upper limb thrombosis. And then cerebral venous sinus thrombosis being that occurs within the brain. Again, treated in a very different kind of way and usually associated with a very unique etiology and patient selection. There's also sometimes some that are intra-abdominal, so mesenteric vein, portal vein, splanchnic vein, other ones that happen in an intra-abdominal realm, and we're not going to talk about that in this talk today. Within pulmonary embolism, you may be surprised to realize there are a number of classification systems, one that's anatomical and one that is simply massive and submassive. And within the submassive categories, I think of subsegmental being the are you barely a PE kind of level. Some subsegmental may actually be there chronically without being diagnosed previously. Segmental when it starts to become more serious, lobar, more serious, and then we get into the massive category when we think about the main arteries being involved in particular, the saddle embolus that sits across the main pulmonary artery and where it bifurcates into the main pulmonary arteries left and right. Now with those, we also classify whether there is the presence or absence of right heart strain. This is sometimes seen on CT imaging, but ideally seen with an echocardiogram for accurate readings. In terms of how you assess VTE, and we're thinking particularly in terms of DVT and PE, lower limb DVT and PE obviously in the lungs, the first episode versus whether this has happened recurrently in the same kind of distribution is important, and then whether it's provoked or unprovoked. So those that are unprovoked have no clear trigger as to why these have occurred, and it happens reasonably commonly, and that's when we need to start thinking about whether it may be appropriate to test for a thrombophilia type condition underlying, or looking for malignancy and excluding that malignancy is occult malignancy is responsible for that clot. And in terms of provocation, the common things we think about are things that have occurred within 3 months, and that may surprise you to think that long a duration that covers provocation, but that's the guidelines. It's within 3 months. We think about travel, that's usually overseas travel on a long distance flight. A lot of people use a cutoff of something like 6 to 8 hours. but definitely 12 and above would definitely be in there. We're having a lot of immobility during that period. Surgery that is associated with immobility because of the general anaesthetic and sometimes the prothrombotic nature of either medications or the operation itself. Immobility of any kind of cause. Cancer, again, maybe solid organ tumours or sometimes less likely hematological malignancies, excluding there's a couple of specific ones there that are very prothrombotic. And then medication changes, and we think about particularly the oral contraceptive pill. And you may be surprised to realise that the OCP is not an ongoing cause of provoked PE. It's usually if it's started within 3 months. So someone that's been on the OCP for many years, that technically should not be considered a specific provoking factor, but it still is a risk factor, and it may be something that you then modify to a different medication because of that. Likewise, smoking kind of falls into that category. It can be a risk factor for VTE formation, but is not known to be a trigger specifically for provocation. Once we're kind of thinking, there is some history here, thinking about unilateral leg swelling, whether there's edema or just that they feel there's tightness, whether there's erythema overlying, which is not as common as one might think, and tenderness in that way, or just pain without tenderness. We then want to confirm, and it's really important to use the right modality of imaging. It's very easy to use in the legs because we can use ultrasound. It's reasonably accessible, there is no radiation, it's reasonably low cost. And you can use CT venography if the ultrasound is not picking up or is not very clear, particularly in overweight patients, but ultrasound usually does the job. In terms of pulmonary embolism, we really think CTPA, so that's CT pulmonary angiogram, and it's the timing. The CT itself is the same, but it's where they take the timing of the CT when the contrast, which is usually inserted into a vein, reaches the pulmonary circulation after going through the right heart. That's the timing of that particular angiogram. We would consider CTPA to be the gold standard for diagnosing pulmonary embolism, but there can be some reasons that you cannot have contrast. They could be difficult IV access, it could be very overweight patients, people that have poor renal function, and those that have a contrast allergy. In all of those situations, the next best modality, which is still a very good option, is the ventilation perfusion scan performed by nuclear medicine that we call a VQ scan. Whichever modality you use to diagnose, it's the same modality you should repeat again before you cease therapy to ensure that the clot has gone. As it's very difficult, particularly when you think about VQ versus CT, the way they image and diagnose clots is quite unique, and it's very difficult to translate between these modalities in an accurate kind of way, particularly with small clots. The last kind of assessment that you would think, only in some cases, is a set of blood tests called a thrombophilia panel or thrombophilia screen. They involve genetic tests like factor V Leiden and prothrombin mutation. They involve factor deficiencies such as protein C and S deficiency, which are generally anticoagulant type factors that help maintain normal hemostasis. And then the more severe end is antithrombin deficiency, also known as antithrombin 3 deficiency, and the acquired antiphospholipid syndrome, which is very thrombotic indeed. So those ones are not ones that you would routinely be ordered, but in some cases, particularly in those that are unprovoked or unprovoked recurrent events, we would very strongly think about a thrombophilia panel. So you've got a diagnosis on clinical suspicion, you've done your assessment, you've confirmed on imaging, it's time to treat this clot, and you may even initiate treatment before you've confirmed on imaging if you feel it's appropriate. So we use anticoagulation. It's so important to differentiate antiplatelet, which is about really aspirin, clopidogrel, ticagrelor are the three that we use in Australia, versus anticoagulant therapy, because antiplatelet is about altering and decreasing the primary hemostasis, and anticoagulant is about modulating or decreasing the effect of secondary hemostasis, and the utility is unique, so don't think that one is the same as the other. And in some cases we use a little bit of both. So we're treating with anticoagulation, and the duration of therapy is determined by the location, whether distal DVT of the lower limb or proximal or PE, and whether it's provoked or unprovoked, whether it's first or recurrent. That's why I highlighted those within the history section, because if you're calling someone for advice, they'll want to know those particular features. And then there's some options. So if you've got you could observe only in some low risk distal DVTs, versus 6 weeks of therapy, versus we double that to 3 months, and then we double that to 6 months. And in some cases we use indefinite therapy. And indefinite therapy can be full dose anticoagulation, but we also now have the availability of using the DOACs, which is the oral newer anticoagulant therapies, using them at a half dose that provides a lower bleeding risk but still reasonable prophylaxis against VTE. As I said before, it's so important to repeat the same modality of imaging at the end of therapy before you cease. So maybe you've determined, yep, this is a provoked distal DVT that's quite symptomatic. I'm going to treat with 6 weeks of apixaban. I would repeat that ultrasound in the 6th week before I cease the drug. There are some options, and more options than ever before as we're practicing today. And my general first-line therapy is the direct oral anticoagulants, or previously called the novel or new oral anticoagulants. And the ones that I like to use are rivaroxaban, which is a daily dose, and apixaban, which is twice daily. I have a preference for apixaban. And you can use dabigatran, but we less use that in this area and more use that in atrial fibrillation. The other option, which is one that we know really, really well, is low molecular weight heparin, which is subcutaneous. So enoxaparin is what we use generally in Australia. Very safe to use, very well known, the utilities there. And often when in an acute setting, when you're not sure what to use, using enoxaparin is a really great safe option for the first 24 hours or longer, especially if you're concerned about bleeding, and then you can transition them onto another agent like a DOAC once you know that they're clinically stable and you're looking at a longer term duration of anticoagulation. Then we've got our traditional ones, warfarin, which in Australia we use Maravan or Coumadin. Really important that you stick with the same tablet because they don't have the same potency in terms of their effect on the INR. And we generally still use that today for some unusual areas of VTE, and we use it for those that have renal impairment. And when I say renal impairment, I mean particularly severe renal impairment, generally below a GFR of 15, as the DOACs can now be used down to a GFR of 15, which is really helpful. Lastly, we've got the more traditional IV unfractionated heparin, which still can be very useful, particularly in a peri-op setting where you really need to control the anticoagulation. And we see that used a lot in critical care where they're at high risk of bleeding. So we need to anticoagulate them to a degree, but no more. And so we might use a high risk protocol for that heparin and close monitoring of the APTT. There are other indications for anticoagulation. The most common, of course, is atrial fibrillation. After that would be treatment of VTE, and then after that would be prophylaxis of stroke in the setting of a mechanical valve, particularly mitral mechanical valves. And lastly, arterial thrombi are quite uncommon outside of atrial fibrillation, but that's another situation that we would be using short or most likely long-term anticoagulation, and generally use warfarin or Clexane in that setting. So how long should we treat people? You've got different circumstances, and like I said, whether it's proximal or distal, whether it's provoked or unprovoked, they are the major factors that determine the duration of therapy. So let's go through some scenarios from the least severe and almost benign to the more severe. In general, a lot of data suggests that the severity of a VTE event is somewhat predictive of a recurrence of that same. So if you were to have a distal DVT, it has a low risk of embolism to become a pulmonary embolism, and it's more likely that if you're going to have another VT event, it will be another distal DVT. Whilst if you have a quite severe PE that may be life-threatening, we would say that there is a higher likelihood in that situation of developing another life-threatening PE, and so we take that more seriously in terms of our duration of therapy, and also in terms of whether we consider indefinite therapy. So the most benign or least severe, we can say, is a provoked distal DVT. So classically, this is long distance travel, an operation, an injury can result in this, and you've got below knee DVT that's reasonably asymptomatic, maybe just minimally symptomatic. We could just observe that or use compressive stockings. In these situations, if you choose observation, you'll generally be doing serial ultrasound to ensure that the DVT is getting better. And we would almost exclusively use this where there is a single provoking episode and the provocation is no longer there, and we would expect normal haemostasis to return. Then we would observe via ultrasound the resolution of that distal clot. And if the clot was not resolving or was getting worse, we would then upgrade to anticoagulation. If we're anticoagulating a provoked distal DVT, the general approach is 6 weeks. Repeat the ultrasound and then cease therapy at that point. Almost all of them will have resolved in that period of time. So let's say that we have a provoked proximal DVT. So this is classically in the femoral vein, let's say, so within the thigh region. that if you have a proximal DVT or a pulmonary embolism that's also provoked, we would generally treat with 3 months of treatment. So that's almost double what the 6-week period is. And again, repeat that same imaging modality at the end of that time before you cease therapy. So let's upgrade again. If we have an unprovoked distal DVT, so this is further down, but it's unprovoked, we would use a similar 3-month therapy. So it's twice what a provoked event would be in that situation. And that's assuming there's no thrombophilia. And we generally, for an unprovoked distal DVT, would do 3 months of treatment and then cease. And then if that were to recur again in an unprovoked nature, we would then strongly consider indefinite therapy. So we see that in that more severe category, those that have an unprovoked proximal DVT, those that have an unprovoked pulmonary embolism, or those that have recurrent unprovoked distal DVT, these are the group that we would treat for 6 months of full dose and then consider treating them long-term with anticoagulation, either full dose or a half-dose DOAC, which is a new option. And that's in the absence of a strong thrombophilic condition. And those are the ones that we strongly consider testing to determine whether we're going to use full dose long-term or reduced dose long-term. VTEs can seem like it was there, the clot was there, we treated it, it's gone, it's done. But actually there are a number of complications that are really important to consider, and timely therapy for the right duration can help prevent these from happening. So the first one is thrombophlebitis. Thrombophlebitis can be the chicken or the egg, because thrombophlebitis is generally an inflammation surrounding a superficial vein thrombus. It can be because there was a skin injury that then has provoked a superficial vein to form a clot, and we generally don't anticoagulate for superficial veins thrombosis because they so rarely embolize. They have to really extend to the deep vein before they actually have embolic potential. But you can actually have that then they become a DVT as an extension of that superficial vein or as a complication of the inflammation from thrombophlebitis. Likewise, if you have a DVT, you are more likely to then develop thrombophlebitis as a complication of the stasis related to that obstruction and inflammation that can occur then. Moving on, post-thrombotic syndrome, which is something that can happen after a VT event, and this would generally be considered to happen in half of people that have VT will develop some form of post-thrombotic syndrome, either short-term or long-term. The most common manifestation of this is edema. So 2/3 of people that have post-thrombotic syndrome develop edema classically in that limb that may be short-term or maybe for the rest of their life. Likewise, you can have venous dilatation. That's really a cosmetic issue, but for some people that is very serious, and you can consider vein stripping to address that long-term. Altered pigmentation happens in 1/3 of patients with post-thrombotic syndrome, which again is cosmetic. It doesn't have any medical issues for the long-term. You can get pain even after DVT has gone, and that's a kind of a chronic pain syndrome, and it can be addressed as such. You can have a feeling of heaviness in that limb with or without associated edema. And you can have trophic skin changes. This is becoming quite rare, and the severe end of that are venous ulcers. That would happen in less than 5% of patients with post-thrombotic syndrome. So very rare, but for those that have it, very serious and can predispose to ongoing infection. A few less common complications would be cryptogenic stroke or arterial thrombi, and this would occur almost exclusively where there is a patent foramen ovale, so a way for a clot to get from the right-sided venous circulation to the left side of the heart and therefore access systemic arterial circulation and cause a arterial clot in a particular organ or digit or likewise. And lastly, one of the 4 main types of pulmonary hypertension, particularly secondary pulmonary hypertension, is called CTEPH, chronic thromboembolic pulmonary hypertension. This classically is multiple or recurrent episodes of pulmonary emboli that then result in areas of the tissue dying off and an increase of blood pressure to compensate for that tissue that's died off, which manifests itself as pulmonary hypertension. This is the main indication within pulmonary hypertension for long-term anticoagulation, and we still do that as a gold standard at the moment with warfarin. That may change to DOACs in the future. So there's a few special considerations that maybe aren't emphasized as much, and I really want to emphasize this if you're a senior student or a junior doctor and you're treating VTE. If you have a malignancy-associated VTE, either because you know they have a malignancy and they develop it seemingly unprovoked, but it's actually provoked by the prothrombotic nature of that clot, of that tumor or disease being present, or sometimes you'll have a seemingly unprovoked clot, and in the investigation of the potential causes for that clot, you find that they have an occult or more obvious malignancy. So in these situations, we actually don't use warfarin, and for a long time, the gold standard was low molecular weight heparin. We noticed that when we used warfarin in these patients, although it can treat the existing thrombus, it makes it more likely that long-term they're still going to develop further thrombi. It seems the warfarin combination with the active cancer is not a good one and can be somewhat prothrombotic. So we've been using enoxaparin or low molecular weight heparin for a long time, and recent evidence has suggested that DOACs are not only reasonably safe, but are probably non-inferior to low molecular weight heparin, and you can use them up front. So we initially started using Clexane and transitioning to a DOAC, as we often do in acute settings, but now it's been proven non-inferior and safe to use DOACs up front with the loading dose and then ongoing therapy. So the big question here is, how long do we treat? Because malignancy is a provoking event. Well, we would treat until the provocating factor is gone. So if someone has terminal cancer or metastatic disease that is either controlled or slowly progressing, that person is going to be on anticoagulation for the rest of their life until the bleeding risk outweighs the thrombotic risk, which it does in some cases, particularly those that have GI malignancies. Upper GI malignancies have a strong bleeding risk, and we might not use DOACs in those particular cases. We would usually use enoxaparin instead. But if you are able to have that cancer cured, and I'm thinking of particularly hematological malignancies have a reasonable cure potential, and there are plenty of solid organ tumours, breast cancer, bowel cancer, that you may cut out in stage 1, 2, or even 3. Once you're in remission for 3 months, so cleared of cancer for 3 months, you can then stop that anticoagulation. And there would be rare instances where we would continue that. The main thing would be to do another scan at that point that you're considering cessation of therapy, and if there's no evidence of thrombus, you can stop anticoagulation, and you'd only restart it if you would have another thrombotic event in future. So that's malignancy-associated VT with some really unique features there. The other one is upper limb DVT. We don't treat this just the same as lower limb DVT. And really, the vast majority of upper limb DVTs are associated with a catheter, in particular an IV catheter or Gelco, so it's an IV cannula, or a peripherally inserted central catheter or PICC line. So the presence of these breaking through the skin, in particular sitting within the deep vein itself, causing a semi or partial obstruction, that seems to predispose to stasis and therefore predispose to thrombus. Interestingly, some people feel that when they find that there's a catheter-associated or PICC-associated DVT, would be the common ones I see, particularly within hematology where we use PICCs a lot, they feel that they need to take out that catheter straight away, but that's not the case. If you're still using the catheter and it's still patent, you can keep it in and you anticoagulate the patient. In fact, there are some people that would argue that we should anticoagulate them for a period of time before taking out the catheter so that we don't dislodge a thrombus in that process and give them a pulmonary embolism. The data on that is not clear, and we need to have better research to understand if that is the case and if there's an optimum period of time to anticoagulate before removing that catheter. Generally, we would think that using peripheral IV cannula, they're reasonably safe to remove, as they're only going to be there for 3 days and they're very short, so the embolic potential there is quite low. Overall, we would consider that upper limb DVT has a reasonably lower risk of embolism compared to lower limb DVT in general. We would still anticoagulate for 3 months as standard for PICC-associated or anatomical issues, and that's usually obstruction or narrowing of the vein in the axillary or subclavian region. That's the other but less common cause in upper limb DVT that should require referral to a specialist. The last interesting group are those that develop a VTE event like a DVT or PE whilst they are seemingly anticoagulated. And if that happens, we first need to determine, were they definitely therapeutically anticoagulated at the time that they had the VTE event, or were they subtherapeutic on their INR? Did they miss doses? There are a lot of good reasons, or maybe even they're taking the right dose, but the drug is being cleared because they're taking some cytochrome P450 inducer or some other factor that we haven't accounted for. So we investigate for that, we test drug levels, we take a good medication history, test INR, depends on which drug that you're on, and we want to check that they are having the right drug at the right time and producing the right anticoagulant effect. Whilst that's occurring, we need to make sure that they are anticoagulated because they've got this new PE or DVT or other VT event that needs to be treated, and it's likely that they need that prophylaxis or ongoing treatment from a recent event if that's the case. So we would generally switch to an oxaparin during that period of investigation whilst we're working out whether their existing anticoagulant option was actually effective. If we find that there were issues with adherence or the drug level was low and we found there's a cause for that, we address that cause and continue on the same agent if that's still the right agent for the patient in that circumstance. If we cannot find a reason for them to have had an anticoagulant interruption or problem with the concentration, we would switch to an alternative agent. That can be a different DOAC if they're already on a DOAC, it can be Clexane if you don't need to treat them for a long period of time, or it can be warfarin. And warfarin has the benefit that if they then have another clot on warfarin, we can in some cases, and this is becoming much rarer, increase the INR target range to anticoagulate them further. It's an option that we don't have available at the moment with DOACs. So that's VTE whilst they're seemingly anticoagulated. So when should I refer my patient with a VTE to haematology? Because haemostasis is a subspecialty of haematology, and there are haemostasis clinics at most tertiary hospitals that would like to see these patients and determine appropriate investigation and appropriate duration of therapy. And they have the time and expertise to do that well. So I would say that all unprovoked VTE episodes should have a haemostasis review, whether that's an inpatient or ideally outpatient review to determine the duration of anticoagulation, particularly because a lot of those patients may warrant indefinite anticoagulation, and it's best to have a haemostasis specialist determine that. If you are having recurrent provoked VTE in the same pattern and reasonably close together, so I'd say if they had a provoked VTE from an operation 3 years ago and they've just had another operation or long distance travel and then had another one, I'd say that's too long a period of time. But if you're having like 3 or 4 of the same pattern over a few years, or 2 or 3 within maybe 12 months of the same kind of pattern, you should get a haemostasis specialist involved there. If you have a VTE whilst the patient's anticoagulated and you can't find an interruption or subtherapeutic dose that's happening, those patients should be seen by a haemostasis specialist. If you're having recurrent thrombophlebitis, there is a role potentially for anticoagulation therapy, and they may benefit from hemostasis review. And then the more rare instance are VTE in very unusual locations or very unclear provoking events. Those are ones, again, falling to that unprovoked VTE category. They are ones that should be seen. So they're the ones that you should think, I may refer this person to clinic, or at least pick up the phone and talk to your local haematology service and say, is this the kind of patient that you'd like to give advice on or that you can follow up with? And that's going to be really better patient care and quality. Thanks for listening. I hope that you've improved your knowledge of how to assess, diagnose and treat VTE events, and in particular, when to refer.